Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the Hem-Onc podcast. We're coming at you from Roloy University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we continue on our colorectal cancer journey, this time talking about adjuvant colon cancer, specifically in that stage 3 setting. And don't worry if you don't remember what stage 3 means. We will review this as we go through the case today. But remember, as you may be familiar with the treatment of colon cancer, staging is really, really important for this disease because it really does play a big role in how we approach things like adjuvant therapy.
Yeah, I'm excited about this one. We're going to break down why we do the things the way that we do. We'll give you a historical perspective, and you walk your way all the way through the idea collaboration and really explain the nuances behind that. CAPOX, FOLFOX, 3 months, 6 months, we'll get through all of it today.
I remember really drilling down into adjuvant therapy when I was studying for boards. Definitely a high yield topic.
Yeah, I haven't taken my boards yet, but I do know on even this year's ASCO ITE, there were a few number of questions on this. So definitely a high yield episode for sure. All right, y'all. So then without further ado, let's go ahead and roll that show. Listeners, before we started recording today, we were talking about what's on our menu for dinner. And, I had meal prepped like ground chicken to make very simple tacos. Meanwhile, our resident chef, Dr. Hausrath, said that he had a simple recipe that he was doing, something out of the New York Times. And I thought that maybe today we could start the show by Dan telling us the most extravagant dish he's ever made, because I guarantee it's 100 times more extravagant than anything I've ever done.
I don't know. Extravagant, complicated. I'd say it's tied between either like a lasagna, like a from scratch, everything lasagna, the process of making and then cooking and then icing and then rinsing and scrubbing and washing and then drying the noodles before you use them. And then like the sauce that takes all day to make, that's a whole thing. But the beef Wellington I made for Christmas was also quite a process. You cut the roast, you tie it, you sear it, bathe it in mustard, let it sit for a while. You make a mushroom paste called a duxelle. You cook that down. You slather it all over. You wrap it all up like a burrito with prosciutto and a crepe to seal in the juices, and then make some puff pastry, wrap it up in that, make another thing of puff pastry, cut it with a lattice roller to make that beautiful lattice on top, egg wash it, salt it, throw it in the oven. It's quite a process, but at the end of the day, you end up with a really, really tasty piece of meat wrapped in a lot of other delicious stuff.
That sounds great. On that note, tonight I have Costco ravioli, and I'm very excited about it. It's gonna be tough boiling that pot of water.
Somebody put in the work to make that happen, Vivek. So, we can't fault that. Guys, Vivek doesn't give himself a lot of credit. I actually think that he dabbles in the culinary arts quite a bit. I would like to make a suggestion that at some point we have a cook-off. I will gladly be the judge if y'all want to do the cooking, and we can settle this once and for all.
It'll be like Beat Bobby Flay, where Dan's Bobby Flay and I'm the challenger. It'll be great.
That's right.
We should definitely do this.
That's right.
Fake Boston accent. Be great.
100%. You got to do it all. I'm getting hungry, so I think we should probably move to the actual episode. This time, guys, we've started on this colon cancer journey this time around. And, previously in our episode, we talked about some of the nuances of our approach to colon cancer management, some of the important information about staging and things of that sort. And now we get to go into the nitty gritty and see how we apply this into clinical practice. And so, Vivek, do you want to start us off with a case of a patient you had recently seen?
All right, so we talked about this case in one of our previous episodes. 48-year-old gentleman comes in for newly diagnosed colon adenocarcinoma, found on a routine colonoscopy, found a cecal mass. At the time, the pathology was notable for this colonic adenocarcinoma that had proficient MMR by IHC and was microsatellite stable by PCR-based testing. Staging imaging showed no evidence of metastatic disease. The preoperative CEA was elevated at 10. He underwent a right hemicolectomy with removal of some regional lymph nodes. Final pathology revealed a well-differentiated colon adenocarcinoma with invasion through the muscularis propria into surrounding tissues, but no invasion of the visceral peritoneum. 4 nodes were involved with the colon adenocarcinoma out of 14 nodes examined, and there was no perineural or vascular invasion. So now he's coming to clinic for us for consideration of adjuvant chemotherapy, and the theme everybody needs to know is to give adjuvant chemotherapy for any nodal disease, and nodal disease means stage 3. So if you're ever learning about this at first, stage 3 nodal disease needs chemo. Through this episode, we'll get into the nuances, though, about this decision. First, can one of you recap the TNM stage for this patient?
Sure. And everyone remember, if you haven't checked out our intro to colon cancer episode, go ahead and do that. We cover the staging in a lot more detail because staging is very important in this disease. We mentioned in that episode, and I'll repeat here again, that looking at the individual T and N numbers that make up that stage are also really important. It helps you understand sort of what you're dealing with in colon cancer. And T staging in colon cancer is based on depth of invasion. And since this is through the muscularis propria, that would make us T3. If it had invaded the visceral peritoneum, that would be a T4A. And if it sort of invaded other structures like the abdominal wall, that would be a T4B. There were 4 nodes involved, which puts us in the N2 category. N1 is fewer than 4 nodes, N2 is 4 or more. And the highest risk group is either a T4 or an N2. And this patient has N2 disease, so we would consider it high risk. And just remember that stage 3 colon cancer is anytime there's nodal involvement, so an N stage other than 0. And stage 2 colon cancer means no nodes, but at least T3 depth of invasion.
So that means that based on what Vivek just said, our patient has a T3N2 disease, which is consistent with high-risk stage 3 colon cancer, as Vivek and Dan just discussed. So remember that stage 3 colon cancer are patients with any nodal involvement. We are saying this over and over and over again because this is the big takeaway that you need to have from this episode. So stage 3 colon cancer patients have nodal involvement. Stage 2 colon cancer does not have nodal involvement, but does have invasion through the muscularis propria layer. We talked about other high-risk clinical pathologic features as well last week that we also need to pay close attention to on the pathology report. Recall that those high-risk features include bowel obstruction, perforation, if there are less than 12 nodes that are sampled, poorly differentiated histology, and perineural or vascular invasion. And it's important, again, to look at these. These are not as important when it comes to the duration of treatment as having either T4 and 2 in stage 3 colon cancer, but certainly still things that we want to note. And we will revisit this again when we talk about stage 2 disease, but again, we're mentioning it here because repetition is key. So Vivek, I wanted to ask you, what is the historical data behind why we do adjuvant chemotherapy for colon cancer as opposed to something like neoadjuvant, et cetera?
So this is where most of our listeners will again fall asleep and totally tune out, but we're going to go through it. Historical data, it's important. It's actually very interesting for colon cancer. From here on, we'll discuss 5-FU monotherapy, 5-fluorouracil monotherapy, and assume we mean with leucovorin. So, the FOLFOX kind of thing. Without the oxaliplatin, you have 5-FU and leucovorin, which is why you have all of those letters in FOLFOX. And in short, leucovorin increases the enzymatic binding of 5-FU and is likely most useful when using a bolus 5-FU rather than a 48-hour infusional. Check out our pharmacy episode for more details on that. The other quick aside is that nowadays, most providers agree that the bolus 5-FU is not needed prior to continuous infusion and leads to unnecessary toxicity. Again, we'll get into that in our pharmacy episode. So now let's get into that historical perspective. There are many older studies establishing the superiority of 5-FU monotherapy over observation in the 1980s for patients with nodal disease. In 1990, there was a pivotal study published by Mortel and colleagues in the New England Journal of Medicine that looked at 5-FU with levamisole. Yeah, everybody heard that right. That's an anti-Helminth drug, levamisole. I remember one of my attendings in my VA clinic had told me about this. Like, yeah, we used to use levamisole. Like, what are you talking about? That's insane. So it's kind of interesting where we've come from. So you'll see some patients always talk to you about taking dewormers for their cancer. Well, technically, there's kind of a historical basis for this. This was literally a dewormer that they took, and the thought was that levamisole had a positive immunomodulatory benefit with upregulation of MHC1 and upregulation of other parts of the immune system, including NK cell activity, to have tumor efficacy, which is kind of fascinating. But in that early study, they found a 30% benefit in overall survival for those who got 5-FU and levamisole. Then we got smarter over the next couple of years, and there was many cooperative group trials in North America and Europe that showed 5-FU with leucovorin monotherapy was the way to go, and that levamisole really didn't add anything and is appropriately scrapped. We basically found, hey, levamisole is not doing anything. This is an important thing. There were 2 meta-analyses conducted in the early 2000s that we'll link to our show notes that established the likelihood of recurrence with surgery alone versus 5-FU monotherapy. And I think this is really telling because it really tells us the natural history of colon cancer if you're not going to give adjuvant chemotherapy. And patients are going to ask you that question. Doc, what happens if I don't get anything? And this is what you can tell them based on these studies. So the absolute risk of recurrence was thought to be about 20% for stage 2 and 30 to 40% for stage 3 if the patients didn't get chemotherapy. These were improved somewhere between an absolute 6 to 12 percentage points with chemotherapy for stage 3 with nodal involvement. And for stage 2 patients, there's very little benefit. We're talking like 1 to 3% benefit for 5-FU monotherapy based on these older meta-analyses. So the big thing to know is that when we have patients and they ask us these things, relative benefits, when you say there's a 30% relative reduction and blah, 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 we're looking at an absolute benefit of somewhere between 6 to 12% with chemotherapy over surgery alone. And keep in mind, this was in an older era. So, we have those issues of maybe inappropriate staging and things like that. The other critical thing to know is that all of those high risk features that Ronak had mentioned, the less than 12 nodes, the bowel obstruction, tumor perforation, things like that, these were prognostic variables identified from these older studies, so they definitely have limitations, and they're not relevant when we talk about stage 3 patients for duration of treatment and choice of treatment, and we'll get into that.
Yeah, it's kind of wild to think that we were using anti-helminth therapy to treat colon cancer and then feeling like a ivermectin vibe off of that. It also sounds like not much benefit to chemotherapy in stage 2. We'll kind of get into modern data for that category of patients in another episode, but it seems like most of the benefit is really for these stage 3 patients with nodal disease. So what are some of the data that led to approval of FOLFOX for these patients as like the standard of care combination?
Yeah, that's a great question. And having done a few GI clinics throughout fellowship, I can tell you, knowing this trial, the Mosaic trial, will make you look like a rock star when you do go to GI clinics. So during this time period that we just discussed, doublet combinations with 5-FU and the chemotherapy drug called oxaliplatin was noted to be effective in that metastatic setting. And as we've seen over and over again when we talk about cancers, if things work well in the metastatic setting, we try to push that up into other lines of therapy because maybe our patients would derive benefit earlier on. And so the pivotal Mosaic trial is what led to the approval of FOLFOX, so that's 5-FU and oxaliplatin, for 6 months for patients with stage 3 colon cancer. And this was published in the New England Journal in 2004. So what you'll need to know about this study is that the trial enrolled about 1,100 patients with both stage 2 or stage 3 colon cancer from 1998 to 2001. And these patients were then randomized to either 5-FU monotherapy versus FOLFOX for a total of 6 months. The key in this trial is that infusional 5-FU was used as opposed to bolus 5-FU. And what they found was there was an absolute 5% disease-free survival benefit of FOLFOX over 5-FU for the entire population. And when they looked at the subgroup of stage 3 patients, they actually found most of the benefit was derived from that stage 3 patient population. Longer-term follow-up thereafter showed no overall survival benefit for the stage 2 patients, but did show about a 4% benefit for stage 3 patients. And the disease-free survival in stage 3 patients was about 7%. So all this to say, that is why FOLFOX was shown to be the standard of care for patients with stage 3 colon cancer as opposed to stage 2. There was another trial that was looking at the use of bolus 5-FU and oxaliplatin, but this was more cumbersome and had higher toxicity with weekly 5-FU infusions for 6 straight weeks. So that is why currently we still use this infusional 5-FU over the bolus dosing.
So it was clear that patients with nodal disease need adjuvant chemotherapy for 6 months, given the overall survival benefit from Mosaic. And they used FOLFOX in that trial, but what about using capecitabine? And remember, that's the oral equivalent of 5-FU. So what's the data in that?
Capecitabine is absolutely something that, you can think of as almost interchangeable with 5-FU. They really do metabolize down to the same thing. We also call it Xeloda. That's the brand name. And it was also approved for patients during this time period. It's given twice daily, 14 days on, 7 days off over a 21-day cycle. And it was evaluated as monotherapy for stage 2 patients and combined with oxaliplatin in stage 3. Because it's just a slightly different drug, you don't need the leucovorin to enhance drug activity like you do with the 5-FU infusions. And capecitabine plus oxaliplatin demonstrated superiority in disease-free survival over 5-FU monotherapy in a trial that came out just a little while after Mosaic. We'll have it linked to that in our show notes as well. As a monotherapy agent, it performed essentially the same as the infusional 5-FU. There was another study that we'll link in our show notes called EXACT that showed equivalent disease-free survival to 5-FU with capecitabine monotherapy. That was run sort of late 90s, early 2000s. For chemoradiation protocols in rectal cancer, a slightly biologically different disease, we do prefer using capecitabine. It's just a little bit more convenient than an IV medicine. But and this is something sort of counterintuitive to patients a lot of times, because they think, oh, it's a pill, it's not IV chemo. It actually does come with a little bit more toxicity than 5-FU does, more diarrhea, more hand-foot syndrome. If you just kind of think about it, being an oral therapy given over 14 days, it's something that has kind of a longer area under the curve for exposure to the drug. After the Mosaic trial, there were a lot of randomized studies being run to compare FOLFOX and CAPOX, or capecitabine oxaliplatin, either alone or with other agents. There were also some studies looking at duration. Should we be doing this treatment for 3 months or 6 months? And so we'll kind of get into some of that data as well.
So essentially, getting FOLFOX every 2 weeks for 6 months means that our patients end up getting 12 doses of oxaliplatin. And, if anyone remembers learning about Chemo Man back in the day, or when you guys listened to our pharmacology episode, you'll remember that oxaliplatin is associated with neuropathy as one of its major side effects. And so what was the long-term neurotoxicity data on 6 months of oxaliplatin-based therapy?
Knowing this is extremely important as you counsel your patients, as you think about the duration of treatment that you're going to choose, and it'll really give you context for the IDEA trial, and that's what we're trying to do in our show. So if you've ever given FOLFOX, you know how difficult it is to get a patient through 12 cycles. I mean, the neuropathy is real. It's very hard to do. And we'll get to the 3 months versus 6 months duration from the IDEA collaboration soon. You might be wondering, well, why not just use CAPOX? Because oxaliplatin is given every 3 weeks, so you only get a total of 8 doses for a 6-month duration. The key thing to know is that the dose intensity is similar because each oxaliplatin dose in CAPOX is higher than what you'd get in FOLFOX. So there are several retrospective studies and a good randomized trial to evaluate issues with long-term neuropathy that was published after Mosaic, when FOLFOX for 6 months really became a standard of care. One was from a Dutch population-based registry study that was published in the JCO in 2013, and it was really fascinating. They sent surveys out to all colorectal cancer survivors between 2000 and 2008 about neuropathy and quality of life. Over 1,600 patients responded, which was an 83% response rate. If you ever tried to do that in the United States, you would not get that response rate, which is kind of impressive. And this time period was great because some of the patients were not exposed to oxaliplatin and just had 5-FU monotherapy. So you're able to kind of compare and contrast in this population-based study. And the incidence of chronic sensory neuropathy was 30% chronic for those who got oxaliplatin compared to 8% for those who got 5-FU monotherapy. So that's real. Nearly a third of patients are having chronic neuropathy. And this was 2 to 11-year follow-up in the Dutch cancer survivors. And this corresponded to a clear reduction in quality of life. The second important study, and again, we'll link all this to our show notes, was from the Alliance Cooperative Group in the United States, and it was published in the JCO in 2015. This was actually a randomized study where they were trying to test IV magnesium and calcium as a prophylaxis versus a placebo to prevent neuropathy. And the prophylactic treatment didn't help, but the data is still very informative. After therapy was completed at 12 cycles, patients continued to experience neuropathy progression for the next 3 months before they saw improvement. And this is a phenomenon called coasting that you'll see in the literature sometimes. So if you have a patient and they're still having worsening downtrend neuropathy for a couple months after treatment, that's actually normal before you start to see this recovery. At 18 months, about half the patients still had neuropathy and 30% had severe symptoms. So this is real. Again, 18 months, we're not talking about 3 years, but still, that's real. And the interesting thing was most patients had persistent sensory neuropathy in their feet. Motor neuropathy was less common, But still, even if it wasn't pain, the sensory neuropathy in the feet was very distressing to patients and really had an impact on quality of life. The last study that we'll link it to our show notes, was published more recently from Finland in 2019. And they retrospectively looked at 140 patients who got either CAPOX or FOLFOX. And really, there was no difference in neuropathy between CAPOX or FOLFOX, but long-term neuropathy in that study was present in 69% of patients. About a quarter of the patients had grade 2 neuropathy, and 10% of the patients had grade 3 or higher neuropathy, meaning difficulty opening jars, buttoning up shirts, daily functions, which is a huge deal. So neuropathy was real for these studies, and knowing this is really important as you think about, do I need 6 months of oxaliplatin therapy?
Yeah, it is so important to understand the rates of neuropathy and association with the dose intensity of oxaliplatin. I mean, talking a third to 2/3 of patients. Those are massive proportions of people who are going to experience this. So definitely check out those studies that Vivek mentioned. It'll really help you counsel your patients. Getting back to the case, our patient had T3, N2 colon cancer, N2 because he had 4 or more nodes, and T3 because he had invasion through the muscularis. And we always hear about the IDEA trial. We've actually already mentioned it once in passing in this episode. This IDEA study, what was it, and how do we use it to inform duration of chemotherapy in patients with stage 3 colon cancer?
So just as I mentioned, the Mosaic trial was really, really important for you to know, the IDEA trial is also super critical for you to take away from this episode. So remember that in stage 3 patients, we have either FOLFOX or CAPOX as treatment options. But as we've been alluding to, that neuropathy is very limiting and debilitating. So the question became, is 3 months of treatment as effective as 6 months while still maybe reducing the rates of neuropathy, but also having a benefit for our patients? And so a group of international collaborators sought to answer this question, and they call themselves the IDEA group. And IDEA stands for International Duration Evaluation of Adjuvant Therapy, so a clever name. They pulled together data for FOLFOX and CAPOX from 6 separate randomized phase 3 trials conducted in 12 countries, and they all tried to answer different questions but had at least one of the following treatments included in their study design. So they were looking at FOLFOX for 3 months or 6 months, CAPOX for 3 months or 6 months. There were other arms in those trials that were excluded in this analysis. One of those trials, for example, was looking at the addition of things like bevacizumab to chemotherapy. So that arm was excluded from this pooled analysis. They planned a non-inferiority trial with a margin that would tolerate up to 2.7% margin of loss of efficacy in 3-year disease-free survival when comparing 3 months versus 6 months of therapy, corresponding to the upper bound of the confidence interval for the hazard ratio of 1.12. This margin was chosen by the group consensus, and you can imagine that a margin of 4% would have been chosen, which would change the results of what would be considered statistically significant. So from 2007 to 2015, there were over 13,000 patients with stage 3 colon cancer enrolled amongst these 6 randomized trials. And about 60% of the patients got FOLFOX and 40% got CAPOX, with an even distribution for duration given the design of the trials included. So about 3,500 patients got 3 months of FOLFOX, and 3,500 patients got 6 months of FOLFOX. And about 2,500 patients got 3 months of CAPOX, and 2,500 got 6 months of CAPOX. So pretty even on all sides. And then the outcomes were stratified by patient risk based on T and N staging. Low risk was considered T1 to T3 and N1. High risk was considered T4 or N2. And note that the other high-risk features we've discussed previously were not used in this study, so those are considered more relevant to stage 3 disease.
So we had a massive international effort to pull together patient-level data from all these trials to answer this important question. It was really a great collaborative effort. So where did this risk stratification for stage 3 patients come from, with T4 or N2 being high risk? I honestly had always had trouble remembering that category until we prepared for this episode. So can one of you tell us about that?
Same here. Yeah, I always had trouble remembering this as well. Just starting at the roots of all this, there was a pivotal study done by Sargent and colleagues published in JCO in 2010. And it was looking at pooled analysis of older studies from the 90s and early 2000s, looking at patients who received 5-FU monotherapy as adjuvant treatment, particularly patients with stage 2 disease. And it showed that patients whose tumors were MSI high or deficient in mismatch repair, MMR deficient, had worse overall survival and DFS when you looked at all the numbers. And that's sort of a counterintuitive result. Remember, we were talking about how MSI high and MMR deficient is generally a good thing. It's usually associated with better outcomes, but not when they were exposed to 5-FU. And the thought was that chemotherapy is probably blunting the immune response, and it's not allowing that immune surveillance to clean up after the surgery and get rid of residual disease. And so this is why we wanted to look at this specific patient population in the MOSAIC trial to see if FOLFOX had a benefit depending on MMR status. And so there was an updated analysis of the MOSAIC trial published in JCO in 2015 that looked at predictors of outcome, and specifically, outcome by MMR status. Unlike the prior study, there was a trend towards benefit in disease-free survival and overall survival in patients deficient in MMR, although it wasn't statistically significant. And looking at a multivariate analysis while controlling for the stage of disease, T4 and N2 were both adverse risk factors for disease-free survival and overall survival. And so that's why we think of T4 and N2 as high-risk stage 3. And we'll link to both the Sargent and colleagues trial in 2010 and the updated analysis, the MOSAIC trial from JCO 2015 in our show notes. So you can have a look at that there. But that's the basis for this T4 and N2 being high risk.
So our patient had N2 disease. So then based on what Dan just described, he would be classified as having high risk stage 3 disease, as we just mentioned. And so what are the results of the IDEA pooled analysis for the low risk and high risk stage 3 patients? What is the key takeaway from this study that we need to know for clinical practice?
Overall, there was very little difference in the 3-year disease-free survival for all patients when comparing 3 months versus 6 months with either FOLFOX or CAPOX. 3-year disease-free survival was 74.6% for 3 months and 75.5% for 6 months, so a 1% absolute difference. Now, when you look at the confidence intervals behind that, technically this wasn't statistically significant because the confidence intervals passed that 2.7% disease-free survival threshold. So that's how these non-inferiority trials are looking. You're powering for the upper bound of the confidence interval. So statistically, technically, didn't meet significance. You could imagine, what if they changed it to 3% or 3.5% or 4%? Then we would say, oh, statistically, there's actually no difference between 3 months versus 6 months. So very little difference, but statistically speaking, there was technically no difference. Grade 2 neuropathy incidence at 1 month after treatment occurred in 16% for patients for 3 months of therapy compared to roughly 50% of patients for 6 months of therapy. So a drastic difference in neuropathy. Now let's stratify it by low risk versus high risk. So in all comers, really only a 1% absolute difference, but the confidence interval passed that margin where we couldn't say this is non-inferior. For low risk stage 3 patients, so this is not T4 and not N2, right? 3 months of CAPOX was statistically non-inferior to 6 months of CAPOX. When looking at FOLFOX, 3 months of FOLFOX did not meet statistical significance for non-inferiority compared to 6 months of FOLFOX. So you might be wondering, okay, well, what was the actual differences here? So the absolute 3-year disease-free survival difference for FOLFOX was only 2.6%, and it was favoring the 6-month arm. So we're only talking about 2% difference here for 6 months. Is that 2% difference clinically meaningful when it comes to so much extra neuropathy? The absolute 3-year disease-free survival difference for CAPOX was 2%, favoring the 3-month group. Why did 6 months of CAPOX have a lower DFS? Nobody knows, right? It doesn't intuitively make sense at all why that happened. And some of these differences are unlikely to be clinically meaningful, right? There's some statistical noise within all of this data. So I think we have to keep that in our heads when why did the 6-month group not do as well as the 3-month group? CAPOX is also harder to tolerate. That's why you'll still see people say, well, for some patients, maybe we think about FOLFOX. But technically, for low risk, CAPOX 3 months was not inferior to CAPOX 6 months. Can't say the same about FOLFOX. What about for high risk? Again, these were prognostic variables found in an exploratory analysis of MOSAIC that Dan had talked about. We found that when controlling for stage, T4 mattered a lot and N2 mattered a lot. So we said, why not let's just lump them together and do another post-hoc exploratory analysis and IDEA. And what they find? They found that the absolute 3-year disease-free survival difference did not meet non-inferiority when comparing 3 months versus 6 months, which means that you basically need 6 months of therapy is what he was saying. But what were the actual 3-year disease-free survival differences for CAPOX? 3 versus 6 months, it was 0.1% difference in 3-year survival if you look at the absolute raw numbers. But because of the confidence intervals, technically it didn't meet non-inferiority. You might wonder, what if you just changed the a priori thought? Why 2.7%? Why did you choose that? It could be anything else. We might be saying, let's just do 3 months for everybody. That's really what we're talking about here. And the absolute 3-year disease-free survival difference for FOLFOX 3 months versus 6 months was actually 3.2%, so a little bit higher than that CAPOX difference. And 3 months was actually statistically inferior. But again, this is a subgroup analysis. So based on this data, high-risk stage 3, not by the traditional risk factors, but by T4 or N2 status, should get 6 months of adjuvant therapy.
Bring it back to the case. So our patient's a young patient, high-risk stage 3, T3, N2 colon cancer. He didn't really like the idea of going home with a chemo pump and the continuous 5-FU infusion. So he preferred to do CAPOX, and that's what he wanted to do. We'll talk about dose reductions and response to toxicity in our pharmacology episode for this series. The bigger question I have, though, is do we need the oxaliplatin for the full 6 months, or can we stop that component of it earlier, like at 3 or 4 months?
So before we get into do you need 6 months of oxaliplatin, I want to make a couple of comments about why we might see discrepancies between CAPOX and FOLFOX. Why could that be? So the easiest explanation, there's a possibility that capecitabine is a more active drug, and that would be the simplest explanation, right? Done and done. But here at the Fellow on Call, we looked at all 6 of those trials individually included in the IDEA analysis. So for 2 of those trials that compared 3 versus 6 months duration, the choice of regimen of FOLFOX or CAPOX was left to the physician discretion. In the United States, we would only give CAPOX to more fit patients, given increased toxicity, so you could imagine that you might be selecting for a slightly more favorable patient population when you're conducting a pooled analysis. Maybe you're selecting for fitter people who you think could tolerate that CAPOX. There was one CAPOX trial where FOLFOX wasn't an option, and in that case, you could also imagine who you're going to enroll in a CAPOX trial, somebody you think is fit enough to get CAPOX, right? So then you might have some selection bias because you're selecting for a more fit patient. There's a chance that we're seeing more fit patients who might have a slightly different disease biology in the CAPOX arms over the FOLFOX arms. That's very possible when we have this pooled analysis with all these exploratory endpoints. And the data showing that CAPOX for 3 months is preferred in low-risk stage 3 is also an exploratory post-hoc analysis. So we don't have true comparative efficacy data. So those are the limitations of the IDEA trial. Is 3 versus 6 months a definite absolute gold? Absolutely not. So we should think to ourselves, how can we de-escalate things like oxaliplatin and things like that? And there was another systematic review and meta-analysis done separate from the IDEA pooled analysis that was published in the JAMA Network Open in 2019 that we're going to link. And in that study, they showed that 3 months of CAPOX or FOLFOX was not inferior to 6 months. Helped confirm the IDEA collaboration, obviously a little bit different in terms of a little more limitations to it and the way the analysis was done. But again, we're just highlighting why could there be differences? Why was there a 0.1% difference for CAPOX, but a 3% difference for FOLFOX? Are they really that different when it comes to high-risk stage 3 patients? Or maybe it's more similar. But back to the oxaliplatin question, Ronak, is there any data on stopping oxaliplatin early, even if you're continuing monotherapy 5-FU for that total 6-month duration?
I think people will see differences in approach to this clinically, but most physicians and providers are stopping the oxaliplatin after 3 or 4 months of therapy to mitigate that chronic neurotoxicity. And in order to address the difference in efficacy, there actually was another pooled analysis that was published in JCO in 2023, because you can imagine a lot of people were asking this exact question. Do we really need to subject our patients to potential neurotoxicity? I think I've said this in a lot of our other solid oncology discussions before, but it's really important to remember, right? These are patients with curable disease that already underwent resection, right? So as far as we know, all of their disease is out of the body. What we're then doing is giving them almost like this insurance policy to try to decrease the risk of their cancer coming back. And so if we are subjecting our patients to unnecessary toxicities, is it really worth it? And that is why these conversations are so important. So this JCO article in 2023 included 11 randomized adjuvant colon cancer trials from the ASCENT and IDEA databases. And ASCENT stands for Adjuvant Colon Cancer Endpoints. So this included 10,000 patients, and what they looked at was the impact of early discontinuation of all treatment and early discontinuation of just oxaliplatin while continuing the 5-FU or capecitabine monotherapy. Long story short, they found that there was no difference in disease-free survival or overall survival with early oxaliplatin discontinuation if more than 50% of the intended doses were delivered. That's huge. I mean, this data right there supports the notion and supports what people were doing clinically in practice, that stopping the therapy early, stopping the oxaliplatin early while continuing the 5-FU or oxaliplatin was still giving our patients benefit. There was inferior disease-free survival and overall survival if all treatments were discontinued early. And again, this supports what we were doing in the clinics. So what this showed and what this confirmed was that perhaps if we find a patient with high-risk disease, we recommend doing the full course of, for instance, 6 months of therapy. And maybe we stop our treatments halfway through, even if people are doing well, to try to decrease that risk of neurotoxicity and long-term complications, but understanding based on these data that we're not going to have major impacts on their overall survival and disease-free survival. I mean, I think that's a slam dunk. I'm really glad that they performed this study, and all of this happened in the time that I've been in fellowship. So it's good to know that we have data to inform what we were already doing.
Yeah, definitely. It's that, stop the oxaliplatin early. You can keep 5-FU monotherapy or capecitabine monotherapy. How much different is actually 3 months versus 6 months? Small potatoes, right? Very small potatoes. So I don't think we need to be thinking, oh man, my patient's having toxicity, I have to push. That is not what we're talking about here, right? We are talking about small differences. All this data is really fascinating. There's considerations of giving oxaliplatin doublets for somebody above the age of 70. It's a big controversy on what you should do. And there's a meta-analysis that we're going to link to our show notes that showed essentially that it may not help compared to 5-FU monotherapy. And we'll link that in, check it out, see what we talk about it in our show notes. But really, just knowing that patient fitness is also important when you're considering this drug that causes a lot of neuropathy. So remember that stage 3 colon cancer means nodal involvement. All people need chemo. FOLFOX and CAPOX are options. Neuropathy with oxaliplatin is real, and we do to minimize the dose intensity to help prevent chronic neuropathy. High-risk stage 3 is T4 or N2 based on a multivariate analysis of the MOSAIC trial, not the other factors that we talked about. For high-risk stage 3, 6 months of therapy is standard, and that it's okay to drop the oxaliplatin, like Ronak said, after at least 50%, so 3 months of the therapy. For low-risk stage 3, 3 months of CAPOX is preferred, but know that FOLFOX for 3 months is probably fine. You heard our thoughts, our hypotheses on why there may be these discrepancies. MSI high or deficient MMR does not preclude adjuvant chemotherapy in the stage 3 setting, but there's an ongoing trial looking at adjuvant chemotherapy with immunotherapy for those patients, so stay tuned for that in the future. So excited to wrap this up today. Guys, any final thoughts on the episode?
No, I thought this was a great discussion. And, in our show notes, we'll also include some of the awesome graphics that a lot of us have seen throughout our training that help provide a pictorial representation of what we're talking about. The information that we discussed today is so high yield for both clinical practice and also for your board exam purposes. So definitely go back, take a listen. I think, again, at the end of the day, understanding some of the concepts that we discussed will also help us in providing guidance to our patients the next time we see a patient with colon cancer.
All right. This was a great discussion. So next time we'll talk about stage 2 and some of the ctDNA and those fun things. So until next time, we'll see y'all later.
Peace.
See you later.